Hello everybody, welcome to Dr. Sam's Anatomy classes. I'm Dr. Azmi Mohsin. In this presentation, I will tell you about the lesions in the visual system. This visual system, is the neurological pathway right from the retina up till the occipital cortex, the geniculate pathway, the conscious visual perception pathway. So if there is any lesion in this pathway, right, there will be a defect in the field of view. You'll find blindness. This blindness, or you can say it's called scotoma in the field of view. So we'll talk about the different lesions one by one. Okay. So before going to the lesions, this is an essential step to know exactly the subject is having defect in which part of the visual field. For that, there is like two ways of asserting. One is the informal way and other one is the genuine way or the precise way. But this one is the informal way, and here this informal way, the subject and the examiner sit opposite to each other, close by, facing each other, and this test is called the confrontation test. This test is called the confrontation test. Here the examiner and the subject sit opposite, close by, facing each other, and the examiner and the subject close one of their eyes opposite to each other, and with the other open eye they focus each other into their open eyes, and such that they have a single, they have a common visual axis, and they should not deviate their eyes. Then while this test is being conducted, the subject examiner should have consistently looking in each other's eye. Okay, then the examiner, with the help of a pen or a finger, he or she will bring it from the periphery, and slowly she will keep moving it towards the center of the visual field, and it is instructed to the subject that as soon she sees the pen or the finger coming from the periphery into her visual field, she should point it with the other hand. So that's way, you can ascertain that she is having diminution in the field of vision or not. Like if the examiner, of course, the examiner should have an intact field of vision. So obviously she is going to see the pen before the subject. If she is suffering from this problem of visual field defect, so she will feel it, she will tell that she is seeing it later on in whatever direction she complains of. So that way you can ascertain that, it's a gross assessment rather. It's a gross assessment to ascertain the approximate site of lesion in the visual pathway. Right. So, and this has to be conducted in both the eyes, right? So if she is facing this problem in one half of the visual field, same of the visual field in both the eyes, so there you can ascertain that the site of lesion will be somewhere beyond the optic chiasma. That's retrochiasmatic lesion. So this is just an informal way to getting the site of the lesion, because the field of view gives a mirror image onto the retina, right? And once again, let me tell you, the upper half of the field of view is represented on the lower half of the retina. The lower half of the visual field is represented in the upper half of the retina. The lateral half of the temporal field of view is represented on the nasal portion of the retina. The medial or the nasal half of the visual field is represented on the lateral half of the retina. So with that, that fibers are conveyed up till the visual cortex. So you have this idea. I have uploaded many lectures upon this before. Okay. Now let's see the other. Now this one is a precise way of visual examination, and this is called the perimetry. Here exactly the subject is asked to sit into and look into a machine here, and instead of those fingers coming from periphery or the pen pointing from the periphery to the center, there are points of light which are projected from the periphery to center, and as soon the subject visualizes this, obviously he will have to fix his focus in the center, and if he sees any point of light entering the field of view, he will press this, and that's how he can detect. This recording will be noted down, and exactly noting down the pointers from different field of different directions, and accordingly the data, the graph will be plotted along x and y axis and will be printed out, and what you will find that the visual field appears like this. So here you're seeing is that the normal visual field, right? This will be a normal visual field, and here you can see that person has a limited field of view. There's blindness in half of the visual field. Now actually let me ask you, like, can you guess this visual field is of right eye or of left eye? Okay, obviously you can see because though you may guess it that it's of the left eye, but to remind you that how you will guess it, because of this blind spot. Now this one is a natural blind spot, right? So this natural blind spot, if you know the anatomy of the eyeball, I told you in the retina, there's an optic disc which is placed medial 3 to 4 millimeters medial to the fovea centralis, and as I told you, the visual field is the mirror image of the image from the retina. So if optic disc, that's the blind spot, that's medially in the retina, so the blind spot in the visual field will be around 15 degrees lateral to the center of the visual field. So remember this. This is the natural blind spot. Okay, and that is around 15 degrees from fovea centralis, lateral, 15 degrees lateral, in the visual field, not in the retina. In the retina it will be medial. Okay. Now in the right eye, this means that he is suffering from this sort of visual problem in this right field of view. So that means the lesion will be somewhere on the medial or the nasal half of the retina of his right eye, or it may be on if you concentrate upon this, if a person is having this sort of lesion on the right visual field, that means he is having some sort of lesion in the fibers running from the medial half of the nasal hemiretinae. Got it? So this is about like how you can read the the images of the visual field. After concluding it from, now I'm going to tell you about the lesions in the visual pathway. I think I should not zoom it, because if I'll zoom it, the part of the image will be out of focus. So concentrate upon this. There you find the two eyes, and the fibers from the temporal half of the two eyeballs, the two retinae, they do not cross, they do not decussate in the optic chiasma, right? They continue straight down into the same side of the optic tract, while the fibers from the nasal hemiretinae, both the eyes, they decussate in the optic chiasma and reach to the opposite visual optic tract. So in this optic tract of one side, actually you are seeing the images of the opposite half of the visual field, right? So the image on this part of the retina will be image on this part of the retina will be coming from this half of the visual field. Similarly, here the images will be striking from this part of the visual field. So that means you are from the left half of your optic pathway, you are actually seeing the images on the right half of your visual field. You have all this idea. I've already uploaded in lectures on the different portions of this visual geniculate pathway. Anyways, so now let's focus upon the lesions. You know that any defect in the field of vision, That's called scotoma. Scotoma is a sort of patchy blindness in the field of view. Now, the lesion number 1 that they have mentioned here is like this one, number 1. We're talking is about this lesion. So this is the slicing of the optic nerve. Anyhow, it might get injured the optic nerve, like, maybe because of the ischemic injury of this, blood supply to this optic nerve, or there may be atrophy of the optic nerve, or maybe due to any trauma. So what will happen if the afferents are completely blocked? So there will be complete blindness on that side of the field of view, right? So images from the complete there will be complete blindness in that eye, while the opposite eye will be completely normal. Got it? Now the lesion number 2. Lesion number 2 is like antero-posterior, the vertical slicing of the optic chiasma, and here the nasal fibers from the two eyes, they were decussating, and that the nasal fibers actually perceive the images from the temporal half of the visual field, right? So you have seen that this nasal retina, they perceive the images from the temporal half of the visual field. So what will happen now if there is lesion of the optic chiasma at this might be compression due to any tumors, right, in the frontal lobe, or might be any compression, or might be experimentally done. So you're seeing here is that what this happens is there will be loss of vision in the temporal half of the visual. These diagrams you're seeing here is not of the retina, right? There's from the diagrams actually depicting the visual fields. So you're seeing there is that loss of vision in temporal half of both the visual fields because of the lesion number 2. Now look at the lesion number 3. Lesion number 3 is like unilateral compression of the optic chiasma from one direction. So if there is unilateral compression, what will happen from one side, let's say here in this from the left side, so the temporal fibers from the retinae of the left eye will get compressed, and that's bringing images from the nasal half of the visual field of the left eye. So there will be loss of vision on the visual field of the left eye on the nasal side, right? So this is the nasal fiber images from the nasal half of the left visual field. So there will be a loss of vision here, and there will be normal vision in the opposite eye in this case. This is all very important because there are questions coming, image based questions these days, so you should have idea of what exactly will be the lesion and the sites. Now look here, this one is the injury in the this is injury in the optic tract. So if there is an injury of the optic tract, or let's say at the LGB, or let's say at this optic tract, optic radiations, number 5. So any lesion beyond the chiasma, retrochiasmatic lesion, will cause homonymous hemianopia, means the same half of the visual field will be lost of the opposite eye, of the opposite side, because the fibers, the images, the blue color diagram I had shown you, the images from the right visual field of both the eyes, they are coming here in the optic tract. So if there is a lesion beyond optic chiasma, there will be homonymous hemianopia. But here, because it's happening here on the left side, so there will be, you can see this number 4 and number 5, both the sides, the lesion will be right-sided homonymous hemianopia. Homonymous means same side of the visual field is lost in both the eyes. So this will be hemianopia, means half the field you are not able to see. So that is the case here. It will be easy to remember that beyond the optic chiasma, the lesions will be like this, the homonymous hemianopia of the opposite half of the visual field. Okay, now in this diagram they have shown another thing, and this they have shown that there is a lesion at number 6. Number 6 is this lesion here. That this from the LGB, the fibers, the 90% fibers from this LGB, of this 90% fibers of the optic attract, they relay here in LGB, and they are projected via this optic radiation, and therefore the conscious visual perception, and they reach there. And these are actually the fourth neurons or the third order neurons. The different terminology I have been repeating. They are the fourth neurons if you include the photoreceptors in this pathway, or they are the third order neurons if you consider the rods and cones as the receptors. Then they'll be the third order neurons. So the images is formed here, and remember that the images formed here is such that the periphery of the retina is represented here, while the macula of the macular fibers, they project posteriorly at the occipital pole. So what happens if there is a lesion which is not reaching to the occipital pole? So there will be loss of peripheral vision of the opposite half of both the side of the visual field, but the macula is spared. Why the macula is spared? Because the lesion is not reaching up to this, and if mostly is this optic striae, the visual striae, the on this portion, this occipital pole is spared because of the dual blood supply. I told you that the blood supply is by the two arteries. This surface, is inferior surface, and the blood supply here is by, this artery called posterior cerebral artery. But because this calcarine sulcus, that's a visual striate area, it's a complete sulcus, and there's a progressive growth, exuberant growth during the development, that this sulcus reaches beyond the occipital pole and extends onto the posterolateral surface, supralateral surface, and in the form of post-calcarine sulcus, which is an example of axial sulcus. And on the supralateral surface, there there is a blood supply, different blood supply, and that supply is by middle cerebral artery. So the macular fibers, they have dual blood supply, and that's why it gets spared. This portion is spared. Remember that this portion is having dual blood supply. That is called the macula. Dual blood supply. Dual blood supply on the macular fibers. Okay, so that was about this diagram. Let's move to another diagram. They have they've shown it differently a little bit, so more images. Now look here, in this visual pathway they have shown is this type of defect in the visual field. The lower half of the visual field, there is blindness in the lower half of the visual field of the left eye. That means the upper half of the retina of the left eye is injured, right? And why will this be injured? The cause of injury may be because, remember, this may be basically of the ischemic cause. The central artery, when it reaches from the optic disc, it actually gives its two branches, upper and lower branches. I have taught you about the blood supply of retina. So when it gives upper and lower, both of these branches, upper and lower branches, then they divide into the nasal branches and the temporal branches to supply the four quadrants, while it gives an additional branch on the lateral side, and that's for the macular or the fovea centralis. So it gives actually 5 branches, but initially it gives 2 branches, upper and lower divisions. So if there is an injury of the upper division of the upper division of central artery of retina, there will be injury of the upper half of the retina, and that will cause defect in the lower half of the visual field on that eye. Got it? So this is called the lower hemianopic hemianopia, lower hemianopia of the left eye. Got it now? Hemianopia basically means like half of the visual field is lost, so that we call it as hemianopia. The next here is the number 2, and number 2 is already I have discussed. If there is an injury of optic nerve, right, and this can be basically at the optic disc also, where there's like less of blood supply. I mean, there is more of nerve fibers compacted at the lamina cribrosa, although there is an arteriolar circular circle of Singh, but there are chances of injury of this optic nerve, so they will be that will cause this type of blindness. And remember, this kind of complete blindness in one eye of this complete loss of vision, that is called amaurosis. Now, amaurosis is complete defect in the visual field. There is complete blindness in one eye, and one I told you might be the reason is atrophy of the optic nerve, right? So that is amaurosis. And the other one is amblyopia. Amblyopia is like some other causes which are compressing upon the optic nerve or the nerve fibers in this. Remember, they are the second order neurons, the fibers of the ganglion and layer. So if there is compression of this portion of the optic nerve, this will cause amblyopia, that is diminished or decreased vision. There is only this difference between the two nerves. The amaurosis is complete blindness, and amblyopia is gradually diminishing in the field of view. The field of view will not be clear, and there will be less of brightness, and the field of view, the perimeter, the area also will keep diminishing. That's amblyopia. Okay, now in this lesion number 3 that I have already discussed, because if there is optic chiasma, vertical lesion, there will be loss of nasal fibers from both the retinae, there will be temporal loss of field of vision, and that's called bitemporal and heteronymous hemianopia. Remember, heteronymous means not the same side of the visual field in the two eyes, so we call it as heteronymous hemianopia. And now this, remember, is a special term given, that's called the tunnel vision. This is, if they ask give any example of tunnel vision, so I mean out of different sides of lesion they can ask like which lesion will happen into a tunnel vision. Tunnel vision is like when you have the temporal fields of view of both the eyes is lost, so you can only see through the actually the temporal retina. Actually you can see is that the central portion or the medial half of the visual field will be intact, so you cannot see on the temporal sides with both your eyes. So this actually is called, have you seen those horses in the races? They are like put blinders on their eyes from both the sides, so that they do not get distracted, and they run fast in whatever they are seeing in the front on the axial view. And that's why this is called tunnel view, like vision only in the center, not on the lateral side. So this remember that lesion, the vertical lesion of the optic chiasma will lead to a tunnel vision. Then optic tract, optic LGB, optic radiation. If there is a complete loss, remember, if there is complete loss of this complete loss of injury of optic tract or LGB or this optic radiation, there will be such type of lesion, and that will be homonymous hemianopia of the opposite direction of the field of view. So remember that this post-chiasmatic lesions will cause homonymous hemianopia of the opposite direction of the field of view. Got it? Now this another special cases, let me tell you this from LGB. The fibers, once again remember that fibers from the ipsilateral fibers will converge on lamina number, remember 2, 3 and 5, and from the opposite or contralateral retinae, fibers will converge on lamina number, remember 1, 4 and 6, right? So this is how this fibers relay here. Now from here, actually remember the fibers representing the lower half of the retina, right? fibers representing the lower half, the retina, they dip downwards, forwards, and they cross. This is happening here in the temporal lobe. So the fibers dip downwards, forwards, and they wind around the inferior horn of the lateral ventricle, and then they move beyond and they reach the occipital cortex through the parietal lobes. Now this portion is called the Meyers's loop. Meyers's loop is, let me draw it here so that you get it. This portion of the fibers is the Meyers's loop, right? So these fibers which are representing the lower half of the retina, and the lower half actually help you see the upper half of the visual field. Got it? So remember that this portion, the Meyers's loop, actually is more susceptible. This is more susceptible for injury. The reason is it's more superficially placed in the temporal lobe. So any sort of injury on the lateral half is laterally on the skull, or if there any lesion on the temporal lobe, these fibers are more susceptible to get injured in the temporal lobe. And another reason, if you compare the upper fibers from these fibers, actually, I'm drawing it with a different color. These fibers, you can see these fibers are reaching here also, but these fibers actually represent the upper half of the retina. So these fibers, of course, you can see have a longer course. These are the few points I have mentioned here which make the Meyers's loop more susceptible to injury. So these are having a longer course, and the fibers, lower fibers of the optic radiation. Got it? So this is the few reasons why Meyers's loop are having more chances of injury, and they represent the lower half of the retina, and otherwise the vision they capture is from the upper half of the visual field. So what happens if we're talking is about the lesion here, the E number lesion, right? If Meyers's loop is injured, so as I told you, opposite half, the visual field there will be defect in the opposite half of the visual field, right? Now in opposite half, only the upper quadrant, right? Because if there is a complete loss, I already discussed, there will be hemianopia, right? Homonymous hemianopia. But if there's a Meyers's loop defect, so because it's the representing the lower half of the retina, so that means upper half of the visual field and only the upper quadrant, right? So that means this portion which is spared, right, and that is because of the green color, that's like the fibers representing the upper half of the retina, because that's why this area is spared. So because you're seeing that there's a through the perimetry, when you draw this graph after examining the subject, he or she will complain that she is only defect in the opposite, or you can say if on the right half of the visual field in the upper lateral quadrant. So this type of lesion is called right superior quadrant enopia. Right superior quadrant enopia. Got it? Or you can say right superior quadrant homonymous enopia. You will not use the word hemianopia, but you can use the word homonymous because they are of the same type, same side. And remember that this type of diagram, if it comes sometimes in exam, you have, they can mention it with a different word. This type of lesion is called pie in the sky. Pie in the sky. This type of lesion is called pie in the sky, right? They can ask you in this type, giving it this making up a sentence and asking which of these lesions is called the pie in the sky, or maybe in this part of the visual tract lesion at which side will cause pie in the sky defect. Okay, then talking about the lesion here that they have mentioned as F portion, but remember F portion they have drawn it wrongly. I should if the lesion is actually they have mentioned is here, so what happens, the fiber reaching to the macula will also be injured. So I would suggest the better representation of the site of injury because of this side of lesion will be this, right? So remember, if lesion is like this, cutting of fibers or injury of fibers mainly of the peripheral half of the retina, so the macular fibers get spared. And the reason I have already told you that the macular fibers get spared because it has dual blood supply, partly from the posterior cerebral artery and partly from the supralateral surface, and that is by middle cerebral artery, and this is posterior cerebral artery. Got it? So it's the posterior cerebral artery which has a dominant role in perfusing the optic radiations. Okay, so I think remember that this vascular lesions of the right, not what you called it, this type of lesion, actually you called it as vascular lesions because the right homonymous hemianopia with macular sparing. So remember this, as I told you, is this type of field of vision will be lost. I mean, this you find in cases of vascular injury. Vascular injury will give you this sort of visual field defect. But remember, this is again important, that if there is a compression lesion, right? Compression means any sort of tumors like meningioma, glioma, right? So if there is a compression lesion, then there will be complete blindness. Complete blindness, I am telling is when there is will there be complete blindness? That means complete blindness. This type of lesion you will find if there is a compression like meningioma or glioma, right? So there will be no macular sparing. Remember this. Okay, so that is from another book. Now this is a diagram to show you that the Mayer's loop, as I was telling, the fibers, like here, this is the thalamus in the posterior portion. Here in the metathalamus there is MGB, LGB. From LGB, the fibers, this from the lower half of the retina, they are winding downward, forward, and then they cross the lower half of the inferior horn of the lateral ventricle, and then the loop around. The fibers are coursing a longer distance, and they are more superficially placed in the temporal lobe, and that's why these fibers are more prone to injury. And I told you the injury, this will be called pie in the sky. Don't forget that pie in the sky lesion will be because of this. And these are the fibers representing the upper half of the retina. All of them, they reach and they converge down here at the calcarine sulcus. Got it? Now this one is again from another book, because I have taken it from different books so that you can cover up all the different lesions in the field of view. So listen here. Now this you can this I have already discussed, right? This we have discussed is amaurosis or amblyopia because of the lesion of the optic nerve, right? That we've done. Then this, because of optic chiasma lesion here will cause this. And remember the another word, this is called bitemporal heteronymous hemianopia. This is called bitemporal heteronymous hemianopia at lesion of optic chiasma. And what another word I told you was this tunnel vision. Remember, tunnel vision. This is also called tunnel vision. Now any lesion beyond optic chiasma, I made you learn this maybe at the complete lesion of the optic tract, LGB, or the complete lesion of the optic radiation. This will lead to homonymous hemianopia of the opposite half of the visual field. Got it? Now look here. The talking is about this lesion, right? Number 4. This is the lesion they're talking about, and this is again I have already told you, it's called the Mayer's loop, area number 4, or they have lesion number 4. So because of lesion number 4, I have already discussed that will cause the pie in the sky type of defect, and this you can call it as homonymous anopia of the right superior quadrant. Lesion is called pie in the sky. Pie in the sky defect of the opposite eye. Pie in the sky defect of the opposite half of the visual field. Then they have shown here. Now this lesion also have to be understood, because it's not necessary you won't have a lesion, but if there is some tumor or some injury, as I told you, the blood supply here is from the inframedial surface is by the posterior cerebral artery. So if there is a lesion here, like at this area number 5, and this is the fibers conveying from the upper half of the retina, and that will project the perceive the images from the lower half of the visual field. So what happens if both the side this happens, there will be complete loss. But tumors or any sort of compressive injury or ischemic injury, if it happens only on one side, so what will happen, the lower half of the field of injury will be lost, but not the other half, because the other half is normal. So what happened, there's a quadrant loss in the lower half of the visual field because of there is lesion in this upper portion of the optic radiation. Got it? So this you can call it as homonymous right inferior quadrant enopia. Got it? And now talking about this lesion is a lesion number 7, as the 6 number lesion. Lesion number 6 you can say is this much, right? So if there is a lesion here, actually again I should clear it that this should be better marked this way, sparing the macular fibers. So if lesion is actually, this is number 6 I'm talking, is this is homonymous hemianopia of the right side, sparing the macula, right? Because macula has a dual supply. You got this one is basically because of vascular injury. Now think about this type of lesion. This is another peculiar diagram. You should understand this also. What will happen here now? This is the occipital pole, right? This is, they have focused, is called the occipital pole, area number 7, right? This is a lesion at the occipital pole, or you can say the post-calcarine sulcus. The calcarine sulcus, because of exuberant growth during the development, moves on the supralateral surface to a small extent, and that's called post-calcarine sulcus. It's an example of axial sulcus, and that represents the fovea centralis. So this can this can happen, injury happen if there is a bang of your skull while in RTA, right? If your head bangs on the forehead. Remember, I told you, if there is a forehead injury, your occipital lobe will bang upon the occipital bone. So in case of any injuries which has exactly injury is localized to this macular portion of the occipital pole, there will be only lesion of this macular fibers. So this will be called homonymous hemianopic central scotoma of the right side, right? Central scotoma of the right side. So that was about the different lesions in the visual pathway. You've got understood. Now just a terminal, just aware of the different terminology related to this visual system lesions. One by one we'll just cover up. Natural blind spot, remember this is placed in the retina 3 to 4 millimeters medial to the fovea centralis, and in the field of view you will find it lateral to the central vision, and this will be around 15 degrees laterally from your principal axis. That was about the natural blind spot. Now talking about scotoma. Scotoma is any defect in the visual field at any area of the visual field. If you find blindness, loss of vision, that that is called scotoma. Then drusen already I have uploaded a lecture on this. These are some yellowish deposition in the central retina which you see on an ophthalmoscopic examination. These are lipoproteins type of substances which are found exactly in the the specialized layer, the first layer. There's a pigment epithelium. It's basically below the pigment epithelium, or you can say between the pigment epithelium and the drusen and the Bruch's membrane, and that's the exact site, and it is more common beyond 60 years of age, and it's more common in females. So that was about drusen. And this is actually, if it's in seen in early, let's be in 40 to 50 years age group, that it means it's a sign of age related macular degeneration. Got it? Now we talk about amaurosis. Amaurosis, I already told you, there is complete blindness in the one eye. The complete field of vision is lost, and might be due to any such slicing of optic nerve, or maybe atrophy of optic nerve, right, or complete blockage of the central artery of retina. So that will be lead to amaurosis. Then the other one is amblyopia. That's called a lazy eye. Amblyopia is gradually diminishing of vision in the gradual hazening of the vision in one eye, completely hazening or gradually diminishing on vision. So that's called amblyopia. Got it? And hemianopia means you are able to see only one half of the visual field in both the eyes, and you are not able to see in one half of the visual field in both the eyes. So that is, it's not necessary for on both the eyes, either maybe one eye also. So one half of the visual field, if it's not visible, then it's called hemianopia. Got it? Then homonymous hemianopia, like when there is loss of vision in one half of the visual field, and that is the same half of the visual field in both the eyes, and that's called homonymous hemianopia. Now heteronymous hemianopia means if you're not seeing in half of the visual field, but of different direction, like from the right eye you're seeing in the medial side, on the left eye you are able to see on the medial side, but the temporal half of the visual field of both the eyes is occluded. So that means you are able to see in different directions with both the eyes. Like closing one eye, you find different views. From closing seeing with one eye of the opposite eye, you find different field of view. So because the field of view is differently seeing, and this occlusion is not of the same side, so that's called heteronymous hemianopia. Remember that I told you example is this tunnel vision is an example of heteronymous hemianopia. Now talking about the upper and lower hemianopia, and this can be because of the ischemic injury of upper or lower division of the central artery of retina. Upper and lower quadrant homonymous anopia, upper and lower quadrant, and that can be remembered because of the Mayer's loop. It will be the upper quadrant anopia of the opposite eye, and in case of fibers on the medial or the superior fibers on the optic radiations, upper fibers, if there will be injury to those fibers, there will be defect in the lower quadrant of the opposite half of the visual field. So that also is related to optic radiation. Now what about papilledema? Papilledema, is, when you go for a fundus examination, you find this optic disc which is bulging, and, that is edematous, and that's called papilledema. The most common cause of papilledema is increased intracranial tension, right? And because of this increased intracranial tension, actually there is diminished vascular return, like the veins of the retina, they get occluded. So there is congestion of blood at this point. So that's called papilledema, and that also causes diminution in the field of view. Then talking about optic neuritis. Optic neuritis is basically any sort of inflammatory causes, might be any infection, meningitis, or which might cause inflammation of the optic nerve. And methyl alcohol, as it is said that it is the most common cause of blindness due to optic neuritis, and methyl alcohol is causing defect here at this optic nerve. And due to optic neuritis, there will be pale when you go for this fundus examination. This optic disc will be not so much edematous, but it will be pale, and there will be also diminution of vision around to this blind spot. Okay. Then Argyll-Robertson's pupil. Argyll-Robertson's pupil was also discussed in detail in my earlier lectures. Remember, this was related to accommodation. So in this there will be convergence will be present, and accommodation will be present. However, pupillary reflex will be lost. So Argyll-Robertson's pupil, convergence is there, accommodation is there, but pupillary convergence or pupillary reflex means pupillary convergence will not be there, meiosis will be not there. And this defect is basically said to be because a defect in the pretectal nucleus. Okay. However, the exact pathway is not, still needs to be explored by the scientists. Now about the Foster-Kennedy syndrome. Now, Foster-Kennedy syndrome is actually compression of the optic nerve because of this frontal lobe tumors. If there is tumor on the inferior surface of the frontal lobe, and that might compress upon this optic chiasma and the intracranial portion of the optic nerve, that's around 10 millimeters. So that because of that there will be loss of vision, and that's called Foster-Kennedy syndrome. Now, how is vision affected due to glaucoma? Glaucoma, is like increased intraocular pressure. So when there is increased ocular pressure, there will be compression of this fibers passing out through the optic disc, and you know that the peripheral fibers emerge out from the periphery of this optic disc to form the peripheral fibers of the optic nerve, while the macular fibers run in the center of the optic nerve. So because of that increase intraocular pressure, there are chances that the peripheral fibers they get compressed, and because of that there will be peripheral diminution of field of vision, right? So your field of view will get restricted towards the center, and that's happening because of glaucoma. So there will be loss of or less of peripheral field of view. Your vision will be centralized. And this already I have taught you is about the pie in the sky. That's a defect due to lesion in the Meyers's loop. So you will find blindness in the upper quadrant of the opposite half of your field of view. Got it? So that's called the pie in the sky. Okay, so I think this is done. Thank you.